Hey, I've been fortunate to have known Jose for, I guess, a little over 6 years. He is one of the smartest and kindest people that I know. He's a graduate of West Point, and from there he decided to continue his education by getting two additional master's degree and a doctorate degree. He is leaving, finishing up a teaching position at West Point, and on his way to being the assistant professor of healthcare administration at the Army Baylor Master of Healthcare Administration MBA program. I'm very excited to have him talk about this very, obviously a very important and relevant conversation for everything that we have going on today. So with that, Jose, I will turn it over to you.
Thank you so much. Just want to make sure that it's working here. The sound perfect, outstanding. So thank you so much, Doug. I really appreciate it. Very happy to be joining in this presentation. This is the second time that I present for third order effects, and I'm really happy to see the network of professionals and experts that you guys have. So excited to be able to share some information, talk to you guys a little bit about COVID and some of the things that I've seen. So with that, I just want to make some disclosures here. So even though I am currently a military civilian and also a reservist, please understand that this presentation is not the view of DoD, U.S. Army, the Military Academy, the Medical Center of Excellence, or U.S. Southcom. Those are the organizations that I'm currently linked to. So I'm presenting this as an independent consultant. So I think that's important to mention. Okay, and one thing that is really interesting, I just moved down to Texas. So for the last 5 days, we have been traveling down from New York down to Texas. And it's quite a change. So very interesting, especially because we moved from the state that was the hot spot for COVID-19, and we have been essentially on lockdown in social distancing since March. Of course, as things are starting to open up a little bit in New York, decided to make the move down here. And things are not going very well. So of course the numbers are climbing, as you have seen in Texas, and it's one of those things that concerns you both as a military service member, but also as a father, right? One thing that was interesting too is I'm originally from Costa Rica, so I'm not in Costa Rica. When you see a snake, it's not a good thing. Not a good thing at all. In New York, not as bad. But this morning we had a nice greeting from a Texas coral snake. So it was kind of interesting. And now I understand that they are in backyards, so I just have to be careful with them. But very similar to what we had in Costa Rica. So interesting story with that. And because this one I'm going to talk to you guys a little bit for today. Talk to you a little bit about coronavirus and current spread. And we're going to talk to you a little bit about the methodology that we're trying to use for the military, that we're recommending. And this is something that we're proposing in order to take care of the issues with data. So we'll talk about that as well, and some recommendations, of course. So this is exactly 60. This is July 3rd, 2014. We were actually deployed with U.S. Army Central, then in Kuwait. And we were looking at an uptick in infections of a novel coronavirus that was called MERS-CoV, Middle Eastern Respiratory Syndrome. So if you look at the numbers, things that are happening now compared to things that were happening back then, 6 years ago exactly, in the Middle East, you see some similarities, right? So we see a really high increase in the last couple of months. Of course, the increase that we see now in the U.S., the increase that we see now in the world is huge compared to the hundreds of cases that we have here. And now, of course, we're talking about hundreds of thousands and millions. But it was very interesting because for us, the mission was to ensure that no service member would get infected with this coronavirus. MERS is very similar to SARS-2. SARS-2, of course, being the coronavirus that we're looking at with COVID-19. COVID-19 being the infection. And one of the things that we saw is that there were some relationships between a specific type of people that was actually getting this. We found out that people that were getting close to camels were actually contracting that. So I'll talk a little bit more about that and what we actually achieved. So this is the team that we put together. I'm not going to go too much into detail, locations and things like that, but we put together a team at that time to look at MERS-CoV. Essentially, it was a mini version of what you guys have seen with the government mobilizing and ensuring that there were no cases within the military population. I am this is me right here. I think you can see the mouse right there. But we also have Doug, of course, who is there as well. One of the things that we did is we immediately reached out to a local host. And we had a series of meetings with them so that we would have mutual collaboration between the two parties. We reached out to the director of the Hospital for Infectious Diseases in Kuwait, and a lot of the information that we obtained was directly from them. So we're really happy about the way that everything worked out. We did have to get everybody together and run through the scenarios and try to get something ready right away, because this was hitting, and it was hitting fast. And you can see right there on the left side one of the flowcharts that we had, just in case we would have a case. And it was very interesting because we did have a lot of really important, a lot of really smart people helping out. So some of the actions taken, we did develop a joint response plan, so that was for all services. We conducted multiple drills, and as I mentioned, we developed a relationship with the partner nations. So we had force protection meetings that included folks from all services in all the partner nations around Kuwait. We met with the director of the Infectious Disease Hospital in Kuwait, and we also presented our work at the RSENT and NISA conference back in DC, also in August of 2014, so that all the information will be shared. So we did recommend actions directly to the commander. And some of the actions were very interesting. One of them, of course, we immediately closed the base to camels. So some folks were not happy about that. It was interesting because people, they want to get their pictures taken, but there was no need to risk more exposure for the population. Other things that we did, of course, we partnered with the Air Force to ensure that we would have a quick way to extract people that would be infected. Some of the lessons learned going through our drills was that we were not as prepared as we thought we were. We didn't have the ability to provide transportation as fast as we thought we would. The limitations was that we would have to extract a person and send them directly to Germany. In order to do that, because of the type of infectious disease that we had, we were supposed to have the bubble, which is basically a negative pressure suite that goes inside an aircraft. So that was one of the things that we had to work with. Also, we didn't have the availability of negative pressure rooms. That was a problem in the host country didn't either. So even though they were there, in order to look at a large number of infectious cases, we would not have been able to take care of that. So we did have isolation quarters, but those were tents. One of the things that was very interesting was the cultural biases. So as I mentioned, the reservoir for this specific type of coronavirus is camels. And as you can see from the picture, they're beautiful, beautiful animals. But at the same time, there's very strong beliefs on that. And people in the Gulf region, they really respect them. They're really, there is not only their pets, it's something a little bit bigger than that. It's part of the culture. So there was some denial on the infectiousness or the infectivity that was coming from camels. So we had to learn to be very careful about how we communicated that. One thing that was excellent too, that we learned was that our test facilities were state of the art. Even though they were field environment, we did have the ability to test for all different types of viruses, including Ebola that actually came out a couple of months later when that first outbreak happened. One of the things that was very, very interesting was, again, the knowledge pool that we had. The folks that we deployed with on the medical side were very, very smart. We had a lot of people, epidemiologists, we had preventive medicine physicians, laboratory technicians. It was like we had a world-class hospital right there in Kuwait, and I was very, very happy to have access to that knowledge pool. Finally, one thing that we had to get used to is that as military members, we do not prescribe, right? We actually are there to support and recommend to the commander on the ground what actions can be taken. But at the end of the day, it's up to the commander what things are there. So something that sometimes in the medical field affect us. Obviously, there's some egos, there's some things there, but at the same time, it's important that chain of command is there so we can have a clear definition of what needs to happen. So I wanted to share that with you because this was something very, very similar to what we saw to what we're seeing now, even though the level of infections did not reach that high. By the way, MERS is still out there, and we're still seeing cases, so it's still monitor that once in a while, but it is not even that big of a problem compared to what we have now. So very important to look at that. So first, before we continue, one thing that I learned is that one person that I know actually did a presentation on safety one time, and they actually had a fire chief and a police chief in the audience. So if you are on the medical field, please share that with me on the chat. I'd really like to know that. Especially because that way it can help for the dialogue as well. And I always learn things from folks in the presentations. I am a professor, and I always tell my students that I learn just as much from them as they do from me. Actually, I probably learn a little bit more from them. But if you are in the medical field, please share that with me. Okay. So I'll talk a little bit about force health protection, so that we have that. And I'm going to. We'll review the chat in a little bit. So force health protection has three specific components when it comes to force health protection in the military, right? We're looking at global biosurveillance, which entails the monitoring of emerging diseases, emerging infectious diseases, and also epidemiology and specific research for infectious diseases. So if we're looking at biosurveillance, The Defense Health Intelligence Agency has some of that biosurveillance that they conduct. I do get daily links from Defense Health Surveillance Bureau as well. So there's a lot of information going on. Sometimes it's not shared, or it's not, maybe shared is not the word, but we don't use it as effectively as we should. And there's a lot of biosurveillance going on. I was actually surprised this year to learn how many people get information on infectious diseases and how many people actually have models that they run. The next portion is epidemiology and research, and that's when it comes to people like myself. I consider myself a computational epidemiologist. I create models that show the spread of an epidemic through time. So those models that you probably have been seeing on TV, where they show you what happened in January when we first got information about this, all the way to now, that's part of the work that I do. So very important biosurveillance portion of it. We do continue to do biosurveillance on influenza-like illnesses. So that information is out there as well. And it continues to be reported, I believe, if it's not on a weekly basis, it's at least on a monthly basis, so we get information on that. Also, the other parts about force health protection, medical research and development. You probably have heard about folks working on a possible vaccine, folks working on the serum. So we're doing that as well from the military. And this portion was actually what my father-in-law did many years ago, when he was actually, and probably he wouldn't want me to say that, but he was actually working on the Ebola vaccine. And of course, now we have one that has been approved and is out there trying to, we're trying to produce more so we can actually use it for helping folks. But the military also does that. So USAMRIID, a very important institute that we use for medical research and infectious disease research. Finally, the last portion is preventive medicine. And that's normally what I have done in the past on the military. Preventive medicine is kind of a catch-all, right? So we have folks that are experts in water sampling. We have folks that are experts on soil sampling, things like that. And we have experts that do things on infectious diseases. So we have, unlike other services, we kind of tend to do a lot of stuff ourselves in the Army. But when it comes to force health protection at a joint level, we all do a little bit of this. So that includes the Air Force, that includes the Navy. I've been really lucky to work directly with the Navy in Italy, and also with the Air Force, great folks. Also with the Public Health Service, which is a great uniform service as well. So just wanted to put that out, because that way we can all agree on force health protection on different fronts. I wanted to show the current picture, what we're seeing. This as of yesterday, and things have been looking really grim. There's some positive signs, but this is the entire world, the entire distribution of what we have for COVID. We do have a little bit more detail or granular information when it comes to the US. As you can see, this map does give you the states, and we have information by county. So very important source of information we can actually use. This, by the way, was developed by the UVA Biocomplexity Institute. I used to be a researcher working with them. So a lot of the folks that developed this I work with, and I used to do this type of analysis. The information that they're utilizing comes from CDC and also from Johns Hopkins University. And I do have very close links to Johns Hopkins. One of my classmates and very good friends is an epidemiologist. They went to school together, so she's doing some excellent work. And she just recently also talked in Congress, spoke in Congress on the COVID panel. Very, very important work. Things that are important here too to look at. We know that data is not perfect, right? I think that's something that we have to understand. And from the military perspective, we have to make decisions. We have to make decisions. Sometimes they're a little bit faster than most civilian organizations would, due to the type and the nature of operations. So for commanders on the ground to be able to make decisions on data that is not always perfect can be a problem. The information that we have here, for example, doesn't show some countries that are actually pretty high. So countries in Latin America, I can tell you that the information that we're getting from Venezuela, for example, is not very accurate, right? Up until a couple of months ago, there was no information coming in. Up until a couple of months ago, Nicaragua was not reporting any type of cases. They're actually reporting it as flu. And all of a sudden they had, from one day to the next, a 2,000% increase in cases because nothing had been reported in the past. And I seriously doubt that all the information is being shared. Some of these countries are just not willing to participate. And even countries that we work close together, they might not have the ability to report information as much, because some of these cases are actually occurring in rural areas, or they might not have the ability to compile nice tools like this, or even report it, or even have the ability to report it up to other sources. So as far as we're concerned, the sources that we use, like CDC, Johns Hopkins, those are very precise on what they give us. The accuracy of that data, however, it goes down to specific countries. So we have to keep that in mind every time that we look at graphs like this. So it's one thing that I always mention to folks. Of course, we're seeing that big increase in Africa, and I just don't think that this is the current picture that we have. I don't think that that is that accurate. So that's one of the things that we do have to keep an eye on. All right, military. So we're going on the military side, and again, we do have the ability to look at data. We do have the ability to report information. So from the military side, cases, of course, have gone up. However, they are mirroring or mimicking what we see in the civilian population. Obviously, military members are part of the civilian population, right? They go home at night. They have their families. Their families are fully involved also with the community. So we have seen increases, especially on those states that are looking at an increase right now. So as of yesterday, there were 57 hospitalized military members. That is the current number, right? There's been, of course, if you look at the cumulative, military is 314. So one thing that has been, that we have been really lucky, as far as we know, is that the ability of, or the infectivity is not as high on those healthy younger populations. That being said, the testing for asymptomatic has increased, and we have found a lot of asymptomatic cases, even in the younger populations. So we just have to be careful about that. On top of that, testing has had its issues, as we all know from the beginning. But the information is there. If you want to look at the information that the DoD is presenting, you can go to this website on the bottom. They have the webpage is called Spotlight on Coronavirus, and it has some really good resources, especially for those of us who are supporting the military organizations. So in let's see, March. So March of this year, we of course saw the big uptick in cases. In February, I started teaching my cadets, my students, about infectious diseases and a little bit about epidemiology. The reason is because I had seen this before with MERS, and I wanted them to be aware that there might be something coming up. So the different folks that we had talked to in the epidemiology network was starting to get a little bit uneasy with things that we had seen at the beginning of the year. Later on in March, of course, things started to go the wrong direction. And we were expecting to see initially just about 60,000 cases, was it confirmed cases? Well, the models were not as accurate. We were using different types of models, but the problem was that we're looking at the typical type of epidemiology that looks at symptomatic cases. And we have learned that COVID-19 has a really high population that does not show symptoms. So at that time, we were in New York, and there were immediate changes. Something that I had not expected to see in my years was to look at full remote teaching when it came to courses that we were teaching. So it was a full, similar to Zoom, similar to this that we're doing, teaching for all courses, everything. Of course, if you saw it recently, the graduation at West Point actually looked like this. So we had the cadets all wearing masks as they moved in and social distance. We also had them come in for 2 weeks before, so they could do testing on them and ensure that they were quarantined. All this information is public, so I'm not sharing anything that is not meant to be shared. But we definitely have changed the way that we do things, especially when it comes to force health protection. So things that have happened since then, we have taken on electronic surveillance systems, and I immediately joined the community that was looking at the DoD models. So there's a very strong community that looks at modeling when it comes to infectious diseases and other threats and health threats for the military. And it seemed that they had every single possible model that there was available. The typical model that we look at for epidemiology is called SIR. Susceptible, infected, recovered model, and is basically a compartmental model. So you imagine three different boxes in which people move from one box to susceptible, so you can get the infection. A variation of that is the exposed, infected, and recovered. Because people also perish. So those initial
Jose, we may be losing the sound.
Especially because
All right, stand by, everybody. We'll get Jose to call back in. Kids in the background, dogs barking, all of the joys.
Can you hear me okay?
Yes, you're back with us.
Okay, outstanding. Hopefully I didn't talk too much before you realized that.
It was just a few minutes that we didn't hear you.
Okay. So I'll try to be a little bit more specific and succinct with this. So anyways, where I was, I had stopped on the portion of the academy. So let me share screen with you guys. Okay. So we did see a lot of measures change, right? So we saw electronic surveillance. We saw that the DoD was doing a lot more on the modeling. Almost every COCOM had somebody that was working on that. DITRA was moving things pretty quickly. The other thing that we saw was respiratory surveillance, so that increased significantly. Fever being one of the main telltale signs of COVID. And then specific testing, right? So we saw some issues with the testing. We saw some issues with, and some of them were actually just on the application of how the testing was happening. So in order to do this swab test, you actually have to go really deep into somebody's nasopharynx to be able to obtain the sample that you need. So some of that was actually giving some issues. But most than anything, what we were looking at was hospital capacity, because we knew that once somebody was going into the severe stage of COVID, we needed to provide with respirators and additional PPE for the healthcare workers. So that went in pretty strong, and also with the military. So I thought that was a pretty good response. Was it at the right time? Well, there's a lot that folks need to discuss on that. I'm not going to criticize the military and the response, critique maybe, but I think that the things moved as fast as they were able to move. And I saw a really big portion of biosurveillance on how fast people are moving. From that, of course, we have the health protection condition levels. And we have seen how bases are reducing in a lot of states, and some bases that are actually increasing. So Joint Base San Antonio is actually at HPCON Charlie. That's the current stage right now, and actually went up from Bravo to Charlie. So we're seeing definitely an uptick here in Texas. So some of the things that I do want to mention is that there are some things that we have to live with. And for the military, it's very important that these things are understood. First, operations need to continue. Things are going to continue. Bad people are not going to stop doing bad things just because we have COVID-19. So we saw that, how terrorists were trying to infiltrate several bases. We saw how activities from other states did not slow down. So operations need to continue. We do not always have the correct data or the most reliable data to be able to make decisions, but that is not new. If you're a commander, that's normally how you operate, right? You don't have 100% of the data, but we have to get things done. One of the things that bothers me a lot from the epidemiology side is we don't know who is infected or effective. And as I mentioned before, normal epidemiology looks at infectious cases to be able to do contact tracing, to be able to create all our models, and we do not have the ability to do that right now. So we do need to continue achieving the missions with a way to protect the troops. And one of the things that we're recommending is a team of colleagues was to develop not another dashboard like in the sense of a model, because we have seen a lot of them. And it seems that we see one on TV every single day, but something that takes into consideration the data reliability of different countries, because our operations are normally outside. So we need to have something that is going to be easy for a commander to know if there's going to be some type of risk and be able to make a decision. So you would say, well, the military does have something for that, right? Composite risk management. And the answer would be yes, and it's a very good qualitative measure. But we do need to have something that can quantify those different risks that we have. So the idea that we had for this one was to create some adjustable scores and measures that would represent the reality in different countries. Some of the assumptions, of course, is that we have inconsistent data, but that we do have the availability to that data. The other great thing is, I have been a member of civil affairs in the past. The other great thing is that we do have the ability to understand how the civilian population works in each one of those countries. So even though this is a medical model, it does look at the stability in each specific country as well. So what we proposed was a model that had two main scores that would combine into a combined risk score. And we try to keep it very simple scores. Basically, the medical risk score would give all the information about what's happening in the country, how many people are being infected, all that information that we have it, but we know that it's not 100% accurate. And then we would have the stability risk score that would include things like the socioeconomic, sociopolitical stability of the country. So a lot of things that do affect the medical threat to troops, but not directly on the epidemiology side. So a combined risk score, I'm not going to bore you with a lot of math, but basically it just looks at a weight between the medical risk score and the stability risk score. And we can change it so we can decide which one is more important, because not every country is going to be the same. Some countries are going to provide information very well, right? Like Europe, we will be able to get a lot of countries that provide really good information. Some countries in Africa will not be able to provide as much. Some countries in Central America as well. So we have to kind of weigh it and see which one is going to help us. From there, we look at specific medical risks. So there's specific measurements that we look at for medical risk, effective reproductive rate being the one that has been really important. So normally we talk in terms of R naught in epidemiology, and that's the reproductive rate. That's how many people you can infect if you are infective. However, because of the inability of knowing a lot of information, we have an effective RT, effective reproductive rate, that is calculated, backwards in a sense. So once people have been infected. So we look at that. Case fatality rate, basically how many people died that have been infected, adherence to non-pharmaceutical interventions, testing. So all these things would go into the medical risk score. They're very important. If you're on the medical field, you know that those things are very important to look and assess. Data validity being an additional measure that we would include. So you sum every single one of those medical factors and you have an additional weight that you do to look at which ones are more important depending on it can be the commander, it can be on decision makers information. So you would look at that information. I apologize for that. That's my dog. And the idea too is that you take that information and you assign some type of importance. So depending on what the commander wants, you could actually assign different level of importance. A medical professional can support that. And then based on the weight, we actually obtain a weighted score that tells us which one of these measurements are more important. At the end of the day, you would have a combined medical score. You would do the same process with the other risk scores. So the stability score would be very similar. And at the end of the day, you would have a combined, and I'm going to go back to this, you would have a combined calculation that looks at the two, at the medical factor and also at the stability score. The idea again is that we would be providing a single number, one single number that is based on science that can actually allow the commander to make a decision on whether or not an operation will happen. So it looks like there's a lot of process and steps that go into it, but once this is established for a specific region, it's something that can be done very simply, and then the commander can make a decision based on that. So I'll go down and I'll show you some of the examples. So we have this example that looks at this South America, and we'll look at the combined scores, so folks and how they're affected in each one of the countries. But then you have the medical risk score and the stability risk score combined. Because they're weights, you can actually change different things. You can actually change the weight for testing, the weight for case fatality rate, the weight for economic impact. And all those things do change the overall combined risk score. And some of the epidemiology information on this model that we developed, and then the stability score that actually looks again at economics, politics, things that actually affect the country. The reason that I wanted to go through that is I wanted to show that there are ways of looking at information, even though we don't have all the data available for this type of disease. And from the military side, it does affect greatly whether or not we can conduct missions based on that. Or we will conduct missions, but in order to know what the risk will be. Another thing that I wanted to mention is that the military does have an authoritative database that looks at all the different cases, all different things that are happening. It includes, right now it has beds, it has ICU, PPE, logistics, medical logistics, and this is called Advana. Advana was a database that was developed initially for accounting purposes, but since it's such a powerful database, has now included all the information from Johns Hopkins, Armed Forces Health Surveillance, CDC. So all that information is included in Advana, and you can actually run some models based on that. So if you're in the military, you can get access to Advana, and it provides some amazing models. So if you're trying to do a model that looks at the data that we have currently available, this is the best resource that there is. All right, so with that, and I know I have gone through a lot of information on COVID, and I probably rambled for a long time. But in conversation with you guys, see if there's any aspects that we can talk about or have questions about. Not without leaving you with some resources that are very important. So I will share these slides so that we can have access to this. CDC, of course, is the main one that everybody has been looking at. But DOD, as I was talking about Spotlight, the COVID Spotlight is very important. Database all the information on what DOD is doing. DTRA, the Defense Threat Risk Agency, used to be called something different. Used to be called the Manhattan Project. And that's a true story. That's they continue with that, but now it's called DTRA. DHA Navy, of course, Navy has all the labs that they have across the world for biosurveillance. They're called the NAMRUs. So you can actually get information about the different NAMRUs and what they actually do across the globe. And then if you want to learn a little bit more about HPCON, this is the website as well. So, Doug, I don't know how do you want to do this, but with that, this is the end of my presentation.
All right. Thank you very much, Jose. That was very detailed and informative. Thank you I know you're in the middle of a move, so thank you for working through family and dog issues. I think all of us have learned dealing with some of those with the new work at home Zoom kind of calls. If you have a question, you can type it into the chat box, or I can unmute your mic and you can ask it yourself. So I see Dennis has his hand up, so go ahead, Dennis, if you can unmute your mic. And
thanks, Doug. Can you hear me?
yes.
All right, great. Hey, Dr. Jimenez, I was wondering if you could do me a favor, go back one slide to the last one. This Advana, you said it provides some analysis capability?
It does. So it is, you have to have request access for it. And if you're a military member, military civilian, you can request access. It is a database, so it's like an SQL type database.
That was me, sorry.
And no, and I've been playing a little bit with the views on it. You can do some queries. So if you're an SQL or SQL enthusiast, you can do some queries and actually get some information. Or you can download the data directly. So I have downloaded a big chunk of data. It's a lot, but you can do it by country or by county. But there's a ton of really great information in Havana, and it is the authoritative source that the DoD simulation group is using.
And it's more than just medical data, is what you're saying, correct?
Yeah. So it initially started as an accounting database. To be honest, so it had nothing to do with COVID or the medical field. But when they started looking at what other things it can do, it is just a great database, very, very user-friendly. So it does have information on medical logistics as well. So it provides information on that. It provides information on infectivity. It has now information about other countries. So I actually requested that. And I think a whole bunch of folks were looking at it, what was happening in other countries. So that's why they included that. And it does use CDC, AFHSB data. So it's very, very precise from them. It's the accuracy or the reliability is what's a problem with the other countries.
Thanks. The reason why I ask is, I work at a civil affairs proponent, and we have a couple of folks who are working on something what we call Civil Affairs Solution Army. And we have a commercial civil affairs solution going on right now where our folks do have access to multiple databases. I'm not sure if this is one they have access to, but I'm going to bring it back to them. And it sounds like something that, if you think it's useful for civil affairs, and it sounds like it is, we could integrate it into the package we have on this CA solution. It's right now, the commercial solution is online, kind of uses open source and pulls from a lot of existing databases already. But I think this might be a useful one as well.
This one is a great one, and again, being part of the military, then if I get your email, I might be able to give you the information to request access.
I can send his email to you, Jose.
Outstanding, perfect. The other source, this actually really, really good source is actually a 100% civilian, and it's from the Helena group, helena.org. So Hotel Echo Lima Echo November Alpha.org, and it is the best, very, very, and they're trying to share it with different proponents, but because it was open source, they were a little skeptical about it. But if you look that up, it's also a good source.
Jose, we have a question in the chat. It says that you showed a graph with 3 deaths and 3,000 cases, which is much lower than others shown in the slide. Anything that can be shared to help reduce mortality in the general population?
So let me see if I go to that case, that slide. This one right here?
Yes, this one.
Okay. So, great question. The problem that we have right now, again, just going back to the nature of this disease, is that it is very difficult to look at symptomatic cases, or asymptomatic cases. Normally, we can look at people who have a cough, people who have a fever, and we can determine, okay, you need to go to the doctor, something's going on. We'll give you a mask when you go into a clinic, and we go on from there and actually look at that case. and then do contact tracing, which is very important. Contact tracing, basically creating a line listing of every single contact that that infected person had contact with, and then checking on them and doing additional testing for them. Because we do not have the ability to do that, it's very difficult to understand who is infected, right? The problem too is that we cannot do contact tracing effectively at this point, looking at the amount of cases that we have on the US population. On the military, the cases have not been that high, and I'm saying that being very cautious, because one case in my line of work is very high, right, for this type of thing. So you still can do some contact tracing to see what's happening with the folks. So one of the things that I would say is testing, being able to test right away, both symptomatic and asymptomatic cases, looking at doing social distancing for everybody. I mean, that we need to continue doing that. The wear of the mask was something that I was a little bit disappointed initially, because we're not asking people to use masks, and then because we wanted to make sure that healthcare workers had enough PPE to do things, but now we're actually pushing it. So I think wearing the mask is important, especially you have two people that could be in contact receiving, being able to pass the infection. One thing that we look at in epidemiology is that the infection is not just a matter of one person is infected and the other person is not, and they're going to pass the infection, but also we look at the time that you share the same location with that person. You look at the distance between them. You look at the virulence of the agent. In this case, the virulence is pretty high, of course. But if you can do anything to reduce the other two, then you can try to reduce the amount of folks that are being infected. Deaths, unfortunately, will come in because of the cases when it goes into a severe case. When it comes to that, right now what we're looking at is trying to develop the vaccine that unfortunately we will not be seeing anytime soon. It's going to be a while. Using the serum hopefully can help out a little bit, but it's going to take a little bit. And serum, I mean convalescent plasma. Some of the things that they have used is the availability of respirators, so technology like that, pharmaceutical interventions. But unfortunately, if you do not have access to those types of interventions, we will see more deaths. I hope that answers the question.
All right, any last questions? Should we wrap up here? Okay, again, Jose, thank you very much. This has been very informative for everybody else. Thank you for attending. This has been recorded and will be available soon to send out. So if you have any colleagues or friends if you think would benefit from the information, you'll be able to pass the link on to them so they can hear it as well. So with that, I appreciate everybody's attending, and I hope you have a great afternoon.